working even with peritoneal dialysis. So nephrologists and anesthesiologists and nurses are specialists of the vascular access and specialists of the exit side of a vascular access. For sure, our problem is the catheter-associated infection. And there we have several risk factors. One is the colonization of the insertion site, but we have even to know we are not sterile on the skin side. The moisture under the dressing, is this dressing really transporting outside humidity or it's accumulating? The prolonged catheter time necessary for treatment, and the technique of placement and the care of the line. For sure, we have different access factors. One is the connection. The other one is the insertion site. Our hands, we should wash, disinfect, and the microflora of the skin. Sometimes we got a secondary infection of our access due to emetic spread of bacteria. So we can talk about intraluminal infection, exit site infection, and catheter-related bloodstream infections. The numbers say that exit site infections are the major cause of catheter-related bloodstream infections. The second cause is the intraluminal infection due to connection and disconnection. So always we have to go back to the guidelines. The guidelines, the old ones, 2011, a little bit modernized about the use of chlorhexidine impregnated dressing in July 2017, says clearly we should use a lot of things. We should be very cautious. We should not permit something to do. We should cautious, especially with the dressings. New ones repeat, new guidelines repeat these facts. Here are the guidelines of the anesthesiologists of America, that we have to use chlorhexidine for skin preparation. If there is a contraindication, you should povidone iodine or alcohol. And you should fix the catheter, but it's not clear in which manner. You should minimize the needle punctures to insert the catheter. And on long term, the insertion site dressings, yes, you should use a bio-occlusive dressing, transparent. You can leave it there up to 1 week. You should use chlorhexidine unless contraindicated. And you should take attention to neonates and younger patients. For sure, chlorhexidine has some problems: irritation, allergy, and skin necrosis. The last ones published in 2022 are repeating many things of how to perform the access before the insertion, how to prepare the patient, or how to go on after the insertion, which additional approaches to use, impregnated antiseptic central venous catheters, which lock therapy to use. But there are even unresolved issues like needless connectors. As we have seen, about 30% of the infection are coming from there, from the connection. How to use these catheters especially or with impregnated with silver or chlorhexidine impregnation. The use of chlorhexidine-based products, and here I'm seeing the bacterial resistance to chlorhexidine. So we have to use chlorhexidine to clean, where to put the catheter, to disinfect, when we change the dressings, and even to use advanced dressings releasing chlorhexidine. How is it working? It's working very well against gram-positive bacteria, Streptococcus. It's weak against Pseudomonas. We have to remember this. And it's weak against virus. And for sure, it's inactive against bacteriospores. So we have to even to differentiate between bacteriostatic effect and elimination of bacteria with higher concentration. If we use it in a lower concentration, we are breaking up the bacterial wall, so the osmotic regulation is collapsing. We are losing potassium, and we get an ionic imbalance, and the bacterial cell is blocked in replication. In higher dosage, we have a loss of the membrane, complete lysis of the bacterial cell, and a cell destruction. But we have even to know if we are using non-ionic soaps to clean the patient, that the chlorhexidine is immediately inactivated. Let's talk a little bit about the adverse reactions. We are not already talking about silver. We have an increasing number of adverse reactions documented in America and in even other countries. That means, due to this increase of use of chlorhexidine and the development of the occurrence of these adverse events, the CDC guidelines remembered and recommend not to use chlorhexidine in premature neonates, and not to use, no recommendations can be made in pediatric patients with an age less than 18 years, because there is a lot of danger and insufficient data. Another point is the use of chlorhexidine are changing genes. Under chlorhexidine exposure, long-term, we have mutations of the efflux pump genes. So there is an increase of efflux pump, and a second mutation of the phospholipids of the bacteria. So it's getting less positive, the membrane. And we have therefore the colistin and chlorhexidine resistance. Other publications are regarding the expression of quaternary ammonium compound resistance. And these are genes which transport easily out several substances and are generating a resistance to therapy or to antibiotic or to antimicrobial substances. We've seen a decreased susceptibility in 7 to 68%. 68% are, in the first case in the upper left, are specimens from endocarditis already treated. Or we have a prevalence of these resistance genes in 2% in a population of American soldiers. And the last one from 2019 has seen in these coagulous staphylococcus clinical samples from several hospitals a decreased susceptibility in already 31%. So we have to think about long-term use of chlorhexidine. Second option, how to treat the exit site is antibiotics. Yes, never use it to prevent, because you're generating other resistant germs. They're only in some guidelines regarding tunneled hemodialysis catheters. They suggest to apply antibiotic creams to prevent infection. We have seen, you know it from the publicity. They say, "Oh, this is killing 99% of germs." But what is happening with the 1% remaining? The 1% is remaining, or is resistant, or is growing rapidly, and it's and the last step, or the fourth step, is transmitting information about its resistance. So we don't use antibiotic creams for our catheters. An option, now we are getting to silver. Use of silver-coated catheters, there is experience, but long-term use, we don't see an improvement of catheter survival or a real reduction of catheter infection, because these catheters are remaining too long and the silver is not reacting for more than 1 week. Or we applying advanced dressing, releasing silver ions. Silver is an old thing, old thing, and for at least 2,000 years. The most knowledge about this is you use silver and silver coins or silver vessels for water disinfection and storage. This is mostly used already in Alexander the Great, the Romans, the Greeks, and in Asiatic cultures. Now we are looking a little bit how does it work. Silver itself does not work, but silver generating silver ions are working. Silver ions are damaging the bacterial cell wall. Unlike chlorhexidine, they create an osmotic leakage, blocking several enzymes of the cell respiration. Higher dosages causing even bacterial DNA damage and apoptosis. As you see, there are several multi-target approaches of silver. We have a good activity against gram-positive and gram-negative bacteria and rare resistance. Silver ions are generated from silver, especially if there is an exudate. So if you have an exudate, you are an activation of silver generation silver ions, and you have an activity of silver. If you don't have an exudate, you will not have or you will not see an effect. So silver treats and prevents, reduces inflammation. Reducing inflammation stimulates even skin regeneration and the healing. But what is happening with the silver on a medication, on a dressing? We will not make a silver a cream over. No, the silver remains there. only a very small amount is released. So the systemic absorption of these silver dressings is quite negligible. If you use silver, you want to even to know about dressing, would like to know how long does it last, this effect, and which germ will be reduced in bioburden. And here you see several types of Staphylococcus and Pseudomonas, and you see there is a really long activity of the several products. So silver dressing have for sure an antibacterial efficacy, let's say high dose, for the last 72 hours. And if you think about a long-term medication, so you have to change it twice a week to have an antibacterial effect. But if you think you need only a bacteriostatic effect, then you can leave it even up to 1 week on place. Think always about every catheter exit site is a wound, and the wound has to heal. The international consensus about the use of silver dressings, it's from 2012, but it's already, there is not an update available, proposes a 2-week challenge of silver use. 2 weeks, then you have to look if there's improvement. Should you continue with the silver or should you not? You can suspend it. So 2 weeks, but not longer, they propose. What kind of infection should be treated? Only localized infections. You can use even dressings, but they are not suggested for the colonization. The latest practice recommendations about silver use from 2019 suggest, well, let's see in the back on the lower part on the right, we have a wound and epithelialization. This is an exit site normally. If it's colonized or contaminated, you use silver dressing. If it's critically colonized or quite an ongoing infection, you should use silver dressings. How to classify an exit site infection? There are several guidelines, and all are looking about the diameter of hyperemia in duration or tenderness about less than 2 centimeters. 2 centimeters is already, for a clinician, it's quite an emergent infection. Or if there is a presence of exudate or pus or fibrin. Clinical use, we are going back to scorings. They are on the right, on the upper part. I propose a scoring which was used in central venous catheters in children from a score for 0 to 3, score 0 and 1. However, there might be a redness, but without fibrin or small amount of fibrin. Score 2 and 3, you see a more extensive redness, about up to 2 centimeters with fibrin or with pus. Score 2 and 3, you should do as one scrap. On the left, these are experiences on tunneled hemodialysis catheters. It's similar, and there even stage 1 and stage 2 don't need local treatment with antibiotics. or a special survey. They should be surveyed, but especially silver should be used in stage 1 and 2. Taking together the experiences about dressings with chlorhexidine or silver, we know from this Cochrane database analysis that as well as chlorhexidine, as well as silver, are reducing catheter bloodstream infections. So we have to think about as an alternative of chlorhexidine. This is an experience from Canada, North America, of several intensive care units, looking about the data of CLAPSI, and they this data up to 2016, up to 2007, they had quite a lot of infections. Then they did some protocols, started chlorhexidine. Under chlorhexidine, you have had a big reduction of collapses. They intentionally switched to silver dressing. They got a significant decrease of infections, which was maintained in several years in the following years from 2010 to 2016. So a patch containing silver on the exit side is working as an alternative to chlorhexidine gluconate. So when to use it? For sure, in the case of adverse reactions to chlorhexidine, think about skin irritation, erosive irritant contact dermatitis, allergic reactions. In the suspect of decreased susceptibility to chlorhexidine, as I already before showed, the cases are increasing. Or in the case of medical adhesive-related skin injuries, there to combine a silicone adhesive with a silver dressing. When you use something, you should even know when not to use it. You should not use it in the case of tunnel infections. There you need a systemic therapy. Or in the case, rare cases, to contact dermatitis to solver. The effect of our approach to the exit side, we see even with chlorhexidine, we see it even with silver, but it's always a product on long term of training, checklists, protocols, surveillance, and audits. There is always a sum which are helping us to maintain low numbers of infections. Thank you.